Дорогие коллеги, наверное, нам...
Dear colleagues, I believe it's high time to start. We are a bit already behind our schedule. So please take your seats. So, good morning everyone, and it's my greatest pleasure to welcome all of you who are with us today at our annual International Hematology School, which is organized and supported by the Roche company and with support of Roche Russia. It is already second school. The first event was extremely successful, and the most interesting in that school was that we had a chance to have a wonderful webcast. So our colleagues from CIS countries joined us, European colleagues joined us from Australia, from US last time. And I do hope that this school would be a very successful repetition of the first one and even more successful. If you allow, I'm pleased to introduce some colleagues of mine who would be moderators and speakers today. Let me start from Evgeny Nikitin, although I am sure that in our country Professor Nikitin does not need to be introduced, but nevertheless, I have to say that he's a doctor of medical science, professor, specializes in CLL, and I want to say that probably all of you in this audience remember this topic that some time ago was called the role of personality in the history. And they always told us, and they taught us, that personality can do really a lot in the history. And I'm sure that Professor Nikitin, in the history of CLL in Russia, he is a personality with capital letter. Wherever he worked in Hematology Scientific Center, Moscow City Hospital, he's writing a history. And we're very pleased that you are with us today here. But also, I want to introduce our French colleagues who are already with us, not for the first time. And the first school took place in Moscow, and I'm sure that they loved Moscow very much. They loved Russian hematologists, and we are welcoming them again. It's my greatest pleasure to introduce Professor Frank Moschhauser, who is a leading specialist in the treatment of the lymphoproliferative diseases from Lille, from France. He works in LISA group that makes very elegantly French style, lots of clinical trials to study different lymphoproliferative diseases, and I'm absolutely convinced that you read that not simple for understanding, the first author of leading publications, of leading journals, and we are very pleased that today he is with us and we are witnessing his presentation. Hello, Frank. Hello, hello. And now I'm giving the floor to Evgeny Nikitin. Evgeny, now it's your turn. Well, thank you very much, Professor Tumyan. Good morning, friends. I would like to continue our introduction row, and I would like to introduce our traditional friend, Professor Luc Isabet from Toulouse, France. Luc is one of the most active investigators and researchers in the area of CLL, and he's author of more than 100 publications, and he's a member of multiple investigational groups. And I believe that the most important assessment of the effectiveness of the scientific work of any scientist are the changes that really change the clinical practice, so-called practice-changing activities. So Luc, he's one of those investigators. Due to his efforts, our routine practice is really changing for the better. And definitely I would like to introduce Professor Gayane Tumyan. She's a professor from Oncology Center. I myself, I will tell you very briefly, when I face quite a challenge, and it's always like that, I always have a tip, you know, I have an option to make a call to a friend. I call Gayane, and I'm sure that 100% he will always help me, and never ever I was disappointed. Now let's say a few words about our program today. So our morning session would be with the support of the webcast, and then upon the finalization of the morning session we split into 4 groups We have 6 unique groups. I have an apology to make. You have to select which one you will join later. The format of this conference is the following. You can have a chance to have direct contact with investigators. This is not solo, this is not lecture, this is active, interactive discussion. So let's recollect the question that was asked yesterday to the audience. Do you have any challenges to the selection of line 1, 2, 3, and further lines of treatment? And if I'm not mistaken, 40% of the audience said yes, it is a challenge to select a proper treatment because the options for CLL and follicular lymphomas treatment, there are more and more, but the number of situations, challenging situations, unclear situations because we face it for the first time, or maybe because it's a very complicated issue, there are many such situations. So maybe you would select a particular group for you based upon those challenges you face, what you see in your clinical practice, because what is very important in the group is a discussion. Also, I would like to draw your attention to 2 technical aspects. Those of you who are with us for the first time, please draw your attention to the following, that in the simultaneous translation device, there are 2 buttons, button 6 channel, 6 Russian channel, channel 5 English channel, and when you leave this audience, don't take the simultaneous equipment with you. That's it from my side. Evgeny, the floor is yours. And Yevgeny Nikitin will be speaking about the real clinical practice in Russia, 1 year of using obinutuzumab in CLL. The floor is yours. Speaking about obinutuzumab, we have been working with this wonderful molecule for already a year. So speaking about this drug, we need to start from the mode of action. So let's briefly comment how it works. Obinutuzumab, as well as rituximab, influences CD20, but I believe that these 2 monoclonal antibodies cannot be even called biosimilars because they're so dramatically different in the mode of action. The modes of action of monoclonal antibodies, there are several of them in fact. This is complement-dependent cell cytotoxicity and antibody-dependent cell cytotoxicity and Fc-mediated phagocytosis and direct apoptosis of the target cells. The degree of involvement of each mechanism in the final of the efficacy of drug is regulated by several factors. First of all, where this process takes place. For example, in blood, what would be more active are complement-mediated mechanisms. In tissues, totally opposite. This is Fc-mediated mechanism and ruining the target. The second factor is the type of lymphoma. We know that CD20 expression in the cells of follicular lymphoma and marginal zone lymphoma is much higher versus CLL. Expression of CD20 is lower there, and the options of the complement activation on the CLL cells is lower. The third factor is the type of antibody, rituximab and obinutuzumab. Rituximab belongs to antibody type 1 and obinutuzumab belongs to type 2 monoclonal antibodies. What's the difference between them? So this subdivision happened long ago. Type 1 antibodies, they actively activate complement, although antibodies of type 2, they do not activate complement, but they work directly on the target. In obinutuzumab, Fc fragment is changed. That makes mechanism of cytotoxicity Fc dependent and more effective. But the most important is that this antibody is still linked with a large loop of CD20 molecule, but it steps several antibodies, several amino acids away. So this difference in CD20 link makes the radical change, because that's totally different mode of binding, and obinutuzumab binds just 1 molecule of CD20 but not 2 as rituximab. So there is no clusterization of CD20 and there is no predisposition to the complement-mediated cell lysis. Obinutuzumab ruins cell targets due to Fc-mediated mechanisms and due to direct toxic effect towards the cells. It appears to be that after the binding with CD20, in the target cells, we observe particular changes. which are reorganization of acting and the transfer and permeabilization of lysosomes. And as a result, the content of the lysosomes gets inside the cell. This is so-called lysosomal cell death. This mechanism is again very different from apoptosis. And I'm sure that the exact details of obinutuzumab mode of action probably not yet totally disclosed, but we know this as a phenomenon, as a fact. And this is also a very well-known slide because it has already been shown many times in different events of Roche company. They show that rituximab effect and obinutuzumab effect towards different cell lines demonstrates different consequences when you cultivate these antibodies with cell lines in absence of any other possible factors guiding the toxicity. Macrophages and C cells complement. So you see there is high lysis, more active lysis with obinutuzumab effect. So this difference in the mode of action definitely leads to the clinical consequences because, as far as we know, obinutuzumab causes high-quality remission with eradication of minimal residual disease. And if patient currently reaches eradications of minimal residual disease, so median of progression-free survival is 56.4 months, although the patient is getting just not toxic chlorambucil plus obinutuzumab, whereas the patients that getting chlorambucil plus rituximab, the efficacy is much smaller and we almost don't see complete remissions. And this is actually my last slide from the general part. I think it's also very important for all of us that if the median of progression, median of time till next treatment using obinutuzumab in combination with chlorambucil is 51 months, if we are speaking about patients that are 75, 79, maybe 80 now, so for many of them, this treatment would become the only one in their life, the only effect towards their CLL, and I think this is very important information for us. So we're using obinutuzumab for 1 year, very first year, so I can speak only the experience that we got from our own hands in Botkinska hospital. For the regimen obinutuzumab plus chlorambucil, 9 patients enrolled. Here you see the baseline patients' characteristics, 9 cases. What can we clearly see? First of all, the age. You see median of the age is 79 years old. So the range from 70 up to 89 years. You can probably tell me that this category of patient is very close to no-go patients, and on my next slide I'm going to convince you that it was not a very slow-go CLL. All these patients require very active treatment. Also, I would like to draw your attention to the comorbidity spectrum presented here. You see pulmonary thromboembolia or aortic aneurysm or advanced atherosclerosis. But with that, SIRS median was just 5, although the range from 1 to 14. And in the next column, where it's more than 3, you see the number of conditions that was assessed by SIRS as 3 plus, So this, and other patients that had one of such conditions, and the other patient had 2. And finally, final column is GFR. You see GFR median was 51 with a range from 28 to 67. So that means that this is more or less standard comorbidity for pretty elderly population. So, and probably you can be a little bit frightened by this slide, but why we decided to treat them this way? You see that vast majority of the patients had stage C. 4 patients had massive lymphadenopathy, massive spleen or massive sizes of lymph nodes, and here you see blood parameters at the baseline level. And this is more than obvious that these are not the ones of soft chronic lymphleukemias where you can use just Licaron. No, this situation required totally different treatment. And then most probably you would treat these patients using combined options, most probably. But we thought that we have some new innovative options and we can try to use them to treat these patients. Speaking about the efficacy, it was more than impressive. When we started, let's say, at the very beginning it went not as we wanted. But later on, we were convinced that the drug really demonstrates very high efficacy because 2 patients reached complete remissions In none of the cases we saw neither stabilization nor progression before. So in all the patients, the mass of disease, burden of the disease reduced by more than 50%. If we speak about the eradication of MRD, so where we assess it in 3 patients, as you can see here on this slide, this is less than 0.01. So that means that this is almost complete eradication of MRD. According to modern classification, this is MRD negative remission. And what is shown in gray color here in this slide, these are patients that have not completed the treatment yet, and definitely they need double assessment of the effect. But even up to now, up to this very moment, the tumor burden reduced by more than 50% in these 3 patients. So this slide simply illustrates the assessment of minimal residual disease, MRD. We see that obinutuzumab plus chlorambucil definitely allows to reach the eradication of MRD. Hematological toxicity is shown on this pretty slide. Neutropenia grade 3-4 was seen in 4 patients. Grade 1-2, 4 patients more. And if we look at the number of cycles, data is shown here. 4% out of 45 available for the analysis had deep neutropenia with reduction of neutrophils of more than 500 cells, and less than 1,015%. Only in 1 case we used GCSF. In no other cases it required. Speaking about non-hematological toxicity, well, infusion reactions, especially for the first injection, yes, it is a challenge. And as we are talking about not of clinical trial scenario, but about real clinical practice, so 2 patients, including the one who was 89 at that time, did not get obinutuzumab in the first line. At first, he had pre-phase by Ligron, so the same course, 10 milligram per square meter for 7 days, and that it allows to reduce for some time the burden of the disease, and then from cycle 2, cycle 3, you can add on obinutuzumab. So what happens if we don't add on obinutuzumab? Yes, you may reach some effect, but this is not the group of patients that could get long-standing benefits from Ligron. So these patients required active treatment. And infections during the treatment were not observed, just 4 episodes in 9 patients for 45 cycles of chemotherapy. At the same time, 2 types of urinary infections and low respiratory tract infection. Why many of us do not love FCR? Just because it causes any problems during the treatment. But the problems related to the immunodeficiency and delayed cytopenias happen usually after the end of treatment. Number of patients develop severe immunodeficiency, and you can do nothing about that. So infections during first 6 months of the completion of treatment, but at that time it was just 5 patients followed up. So we saw it in 4 patients. 4 infections of the lower respiratory tract and 1 infection. Very short term, by the way, and only in 2 cases they required antibiotics. And there was 1 pretty challenging infection, that was herpes zoster. And I think I should draw your attention, maybe for those of you who did not get personal experience working with obinutuzumab, that we need to pay specific attention to the prevention of infusion reactions. This is a very important topic. Infusion reactions, this is any adverse reaction that develops within 24 hours after the start of monoclonal antibody infusion, and the biggest challenge here is differential diagnosis between the anaphylaxis reaction and cytokine reaction, because the consequences of these reactions are pretty different. In anaphylaxis, we never ever should reuse this drug. But in case of cytokine reaction, we simply should stop the infusion, repeat premedication, and definitely continue, because that's the only way to get the success. So differential diagnosis of these 2 reactions is pretty complicated. So we have a special cycle, infusion reactions. So those of you, educational cycle, so those of you who would like to go through this ICU cycle, you're welcome to the website of Botkinskaya Hospital and to join this cycle electronically. And I think before the start of treatments, You need to assess the tumor burden in this patient, so you need to understand whether beta blockers are in the regimen, because in case of hypotension, including uncontrollable hypotension, you will need to administer adrenomimetics and dopamine, and if in the morning the patient got beta blocker, then it will make your situation more complicated. So before the first injection of obinutuzumab, you need to pay attention to that. And also some other factors mentioned here are extremely important as well. What is actually the most important predictor of the infusion-associated reaction? As it may seem strange, this is density of CD20 expression on the tumor cells and also CD16 density expression on NK cells. So if you see these particular levels, the probability of infusion reaction increased threefold. And all that can be tracked using standard immunophenotyping. So all clinical factors, the tumor mass, etc., everything is very important, but these two are of extreme importance. Definitely, obinutuzumab, it is not the monoclonal antibody, because we got used to rituximab, and we pretty frequently have pretty easygoing attention to premedication. But with the first injection of obinutuzumab, you should not be easygoing. Premedication should be done adequately in adequate doses, minimum 30 minutes before you start the infusion of the drug. Besides, obinutuzumab is extremely effective antibody, and you can get tumor lysis syndrome after the first injection, especially in the patients who get the treatment for the first time and that have big tumor mass. And please, I would like to draw your attention that during first 3 days of obinutuzumab infusion and then day 8 and day 15, you need to have active control of biochemical parameters of tumor lysis syndrome, including creatinine, sodium, phosphorus, uric acid, etc. So you have to do it day 1, next day, and day 3. But you remember obinutuzumab 0.1, then 0.9, then 1,000 milligram, and day 15, 1,000 milligram in cycle 1. And the last part of my presentation would be devoted to the using combination obinutuzumab plus bendamustine, speaking about the relapses. Somehow it happened that we in Botkinskaya Hospital started using this regimen even more actively than others. Here you see the regimen itself. This is GB. This is standard regimen, and I would like to remind you that bendamustine is used in the doses of 70 milligram per square meter. We have totally 21 patients, and we had at least 3 cycles, 17 males, average age 65. Here you see no stage A, and 7 patients had stage C, 14 patients stage B. We did not include here patients with 17p deletion because we administer them totally different alternative treatment. Then 9 patients have pretty bulky tumors, but they were not patients in severe cytopenia. Median of time from the start of the disease up to obinutuzumab treatment was 73 months. 6 patients got more than 2 lines of treatment. Almost all of them got rituximab before that, and the other drugs are shown here. And what is also very important is that early relapse after FC or FCR or BR was confirmed in 4 patients, and late relapse in 11 patients, and also relapses after rituximab and alkylating agents in 6 patients. So here you can see that this is not the terrible sampling of the patients. Speaking about the efficacy of treatment, so total response was 61%. 3 patients reached complete remission and 8 patients partial remission. Progression with treatment was observed in 4 patients, and if we analyze the MRD and response, so eradication of MRD was reached in 2 patients in complete remission and in 1 patient with partial remission, and interim results was received in 1 patient in complete remission, in 4 patients in partial remission, and more than 1% in 2 patients with partial remission. So that was the ratio of MRD and responses. 13 patients completed 6 cycles, no no problems. 3 patients were discontinued cycle 4 and 5 because of progression. 3 patients managed to get just 2 cycles, and 1 stopped because of toxicity and 1 refused, and 1 patient had both toxicity and progression. And 2 patients are still on treatment. Hematological toxicity. 33% of patients had neutropenia, less than 1,000 cells, and the number of cycles is shown at the bottom of the slide. So severe anemia and thrombocytopenia were not reported, speaking about hemorrhagic syndrome, so we didn't see that. And GCSF was used only in 3 cases, as I said before. Speaking about event-free survival, it is shown here. It was totally different, depending on what status of the relapse was. Relapse after the alkylating agents plus minus rituximab, this is pink part of the table, so they're followed up and they're getting treatment, and why patients refused after just 2 cycles. Patients with late relapse, everything is very good. 1 patient was stopped because of toxicity, and in 1 patient the progression was observed after 4.6 months. Now, speaking about early relapses, this is the bottom part, which is red color. This is early relapse after FCR-BR. So in this group, 3 out of 4 demonstrated progression, and 3 didn't respond. So that means that possibly early relapse of CLL after fludarabine-containing regimen, probably it's not the optimal option to use obinutuzumab, although our data is still very limited and we need to go deeper. So summing up, I can say that obinutuzumab monoclonal antibody type 2 to CD20 with the fortified direct cytotoxic effect, antibody-dependent cell cytotoxicity, very good tolerability even by very elderly patients. And I would like to draw your attention that in our sample of the patient, the median of age was 79 and SIRS index was 5. And we didn't have any problems. And when using this drug, you need to take into consideration risk factors and preventive measures that help us to avoid infusion reaction and tumor lysis syndrome. Possibly, we can say that obinutuzumab plus bendamustine is not quite effective, but this is very preliminary conclusion in patients with early relapses of CLL. So we, as everyone, thought that these new molecules can be extremely effective, and I know that in many regions, because I'm getting sometimes these patients coming from the regions where in the regions they want to administer obinutuzumab, let's say for the refractory CLL or for early relapse case, possibly this is not quite justified situation. That's it from my side, and thank you very much for your attention. Thank you very much, Evgeny. So, dear colleagues, any questions to Evgeny? Any questions? Yes, Vladimir, please take the mic. No. Evgeny, the dose of bendamustine, I was a little bit confused by that. Could you comment on that? 70. So bendamustine 70 milligram is recommended to be used in the relapse scenario because 90 milligram, that's line 1, and 70 milligram, it's relapse. Thank you. Any other questions, dear colleagues? You're welcome. Microphone.
Sharing your very interesting experience. I would have maybe 2 questions. What is the schedule of Gardasil you used? Either the German one every 15 days or the, let's say, the British one, 1 week every month?
Мы использовали хлорамбуцил.
We use chlorambucil 10 milligram per square meter, 7 days, and then 3-day break, 3-week break. And then next cycle starts on day 29. That's our regimen.
Your safety profile is quite good. Despite you had stage C patients, you had very, very few neutropenic events, and you almost never used GCSF. And how do you handle the first infusion, the first cycle? How do you manage thrombocytopenia or neutropenia, let's say, the first 2 weeks? Because sometimes in my practice, I do not inject Gazyva on day 8 or day 15 of the first cycles. It depends on the blood counts. And after cycle 2, 3, 4, 5, 6, usually there is no problem. So can you, did you have such an experience yourself?
Ну, мы
Well, it happens that possibly after patient 50, after patient 100, we're speaking about the general problems. But when the sampling of patients is very limited, we all have our unique experience. So the example of thrombocytopenia, we had it, we faced it. I'm not speaking about these patients because thrombocytopenia developed very soon after obinutuzumab, and I have no explanation to that. But in these patients that I'm speaking about today and now, about this group, we haven't seen anything like that, like what you mentioned. And we never start cycle, let's say day 8, day 15, we do blood count. Yes, in the first cycle, we never ever start without that. So in the morning, we take biochemistry and blood count, but you have it, you know, in several minutes. And that's why all these patients were properly monitored, and we did not have any examples when acute thrombocytopenia was developed on week 1 or week 2. Maybe Vladimir can have something to add. Evgeny. Luke, any other questions? No? Evgeny, could you tell me, in your patient's profile that you included here, 79 average age, very elderly patients, what do you think? Because in our country, we have very many not so elderly patients because the median of age in CLL is much lower versus European countries. But if we do the same but for the younger population, do you think they would lose or they would win if they get obinutuzumab? I think, well, what we started in this sampling, because when you start working with the drug for the first time, you mainly ground it on the literature data, and we used it upon indications that were clearly formulated by CLL-11 trial, where they included patients with dramatic comorbidities, significant comorbidities, with reduced renal function, etc. So we selected the same patients. Now, keeping in mind this surprisingly high efficacy, I believe for this category patients is really very high efficacy. I believe that now we can make next step and let's say to extend the spectrum of application, and I think it is pretty justified. But again, we need to take into consideration the mutational status as well, because now it has more and more importance. The mutational status of VH genes, because this treatment mainly beneficial, as CLL11 tells, the ones that have mutations in VH genes that have no 17p deletion and that have a low level of beta-2 microglobulin. So these are the patients that get most benefit because their remission is the longest one after albino. But this is our near future. But and I totally agree with you. Yes, we can try to extend. Yes, please. We have one more question. Evgeny, your position, obinutuzumab, can be used for the treatment of relapses, or because I couldn't get from your presentation, is it still early relapse, or it's lack of efficacy, bendamustine, or maybe it's resistance to obinutuzumab? Do you think Gaziva doesn't have place in the relapse treatment? Dear Sergey, I can tell you the following. In early relapses, according to our data that we have, we don't yet see high efficacy. Speaking about late relapse, it's difficult to answer, because I believe that clinical trials should answer these questions. And my experience is very limited. I'm not in a position to comment on that. Maybe I could tell you more if we have a longer period of follow-up, but here the longest follow-up was 13 months. For CLL, it's very limited. Maybe we can refer this question to Luik. Luik, what do you think? The place of obinutuzumab in relapses? Early relapses, late relapses, relapse scenario. With what combination and in which context it's the most effective? Thank you.
So in CLL, I never use obinutuzumab for relapsed patients because it is not allowed to use it like this in France. And then to answer your question, for a patient receiving obinutuzumab plus chemo or rituximab plus chemo with an early relapse, I would rather go on ibrutinib. Because early relapse to an excellent regimen like BG or FCR first line means that you are in front of a very high-risk CLL. And for those patients, BCR inhibitors or BCL2 inhibitors, if you can use them, are the best options. Maybe I can ask a last question.
And what about late relapses?
For late relapses, in France, there is a struggle between those who think that B, G, or BR can be used, depending on the. So many of my colleagues use BR for a relapse, for instance, 7 or 8 years after FCR. A lot of my colleagues use BR. But again, myself, in my practice, I never use BR. Because in all trials, BR is inferior to idelalisib or ibrutinib. And so I try to pick the best option every time. What is the best option first line? What is the best option second line? And I don't try to think, if I use BR, the PFS will be 12 months, 15 months, and then I will give ibrutinib third line. To me, it's a bad calculation. When you treat cancer, you try to give the best drug at each line. If you use ibrutinib second line, I will have another option third line. And now it turns out to be idelalisib or venetoclax. And so that's why I do not use chemotherapy after chemotherapy, also because of outcomes and also because of myelosuppression. I had also some patients with myeloid dysplasia, acute myeloid leukemia, and so to me, after FCR, that's enough. I try to give other drugs.
И это является
And this is the most important and the key thing. This is exactly the place where we go the other way from Europe, because we will never have this abundance of the drugs in the next 5 years. That's for sure. That's for sure. We will not have selection of five or six options that can be easily used and combined as we liked. That is why I believe that we will be able to answer this question ourselves here in Russia, carrying out particular clinical trials. And we will hardly get this information from European colleagues. Thank you. Okay, thank you very much. Dear colleagues, any other questions to Professor Nikitin? If not, then Professor Nikitin, thank you very much. And we continue our work, and it's my greatest pleasure to give the floor to Professor Loic Isabert, who will speak about all the fine-tuning of the CLL. And the only thing I would like to mention is that what it characterizes Loic. Besides highest professionalism, there is one word characterizing you: huge desire to share. Desire to share, passion to share. Take it and use it. You are welcome.
Thank you, Professor Toumian, for this very kind introduction. So over the next minutes, we'll have an overlook on how to decide which treatment to give first line to your CLL patients, with an emphasis on how comorbidities should influence the choice of chemotherapy. So the first question is how to assess patients with CLL first line. And you are all aware of the guidelines edited by the European Society of Medical Oncology. And if you go through the different options, first, many patients do not require treatment. Pay attention to this. Second, some patients should not receive aggressive chemotherapy because they won't respond. Those patients with 17p deletion and or TP53 gene mutation. And for the 95% of patients eligible to chemotherapy, then you have to pay attention to physical status. So very briefly, I remind you that FCR is the preferred regimen if it's feasible in your patients because of the CLL8 and CLL10 trials led by the German group. You already know that there is a strong improvement in both progression-free and overall survival after the introduction of anti-CD20 monoclonal antibodies in the treatment of indolent diseases, including CLL. But CLL was the last lymphoma to benefit from rituximab. And now we have new monoclonal antibodies with different modes of action, as Yevgeny reminded you before me. It's important to keep in mind that in first line, the backbone of treatment nowadays is the anti-CD20, maybe more importantly than the choice of chemotherapy. FCR and FCR is also an excellent regimen to induce eradication of minimal residual disease. And so in first line, one of our goals in treatment is to obtain such deep remission. Of course, you know, even in France, most of our centers do not have MRD available in their lab. So this is something important for the comparison of treatment across trials, but for everyday practice, in my opinion, and in the opinion of most European experts, MRD is not the goal. For you, the goal is a good quality of remission and a good quality of life. We shouldn't use FC or FCR in 17p minus patients. This is just to remind you this evidence. And nowadays, for those patients, first-line option is rather ibrutinib. This is also an interesting chart coming out from the CLL8 trial, and to show you that comorbidities, as assessed by the SIRS score, SIRS is for cumulative illness rating scale. This is one of the tools we have for assessment of patients. So having comorbidities, even in FCR patients, influences a lot the outcome of FCR. It means that comorbidities really impacts on the survival of your patient even after FCR. So at the end of the day, we are left with a very last question, the most difficult one, how to really assess fitness in our patients. So this is one of the goals of several international groups, panels of experts, and I was lucky enough to be part of two of them, led by the International Workshop on CLL and the International Society of Oncogeriatrics. And from the beginning, we asked ourselves a series of questions. And maybe the most important one is, with a specific tool, what do you want to assess? You want to assess frailty, toxicity, outcome? Okay. What do we have in hands? A series of evaluation. And so, if we want to be really predictive, we can use any tool. The problem is, what is the question? If your question is, should I use this drug to have improved overall survival, you have to check 17p minus, and then you have to calculate life expectancy of your patient, etc., etc. And so we have this kind of list. If the question is efficacy of immunochemotherapy in terms of toxicity, outcome, etc., we have some tools. If the question is the likelihood of dying without CLL, we also can use another score, and for instance, the Lee score, which predicts the likelihood of being alive of your patients in 4 years. So remind what Yevgeny told you before. If you have a combination of drugs with a time to next treatment of 51 months, in a patient with a likelihood of dying of 4 years, you will use once CLL treatment. So that's why that's also an argument in your everyday practice, and I often use this score. It is available online, and it's very easy to calculate. This score is used by most geriatricians in Western Europe. And I spoke to you about frailty. So up to now, I didn't say unfit yet, because unfit is quite difficult to define, but frailty is easy to define. If your patient accumulates comorbidities, it has frailty. Frailty means the inability to respond to any stress, stress induced by CLL, stress induced by you as doctors, with FCR, for instance, etc. And so this is really important because in the geriatry experience, the overall survival of such patients is extremely short. So you have to make sure that your patient is not frail at all when you start treatment. And sometimes you may choose for the maybe less active treatment, but with the best safety profile. So this is to remind you the life expectancy in France, but also in the United States. After 70 to 90 years of age, if the patient is frail or if the patient is not frail. And on the left-hand side of the slide, you will see the proportion of patients with different comorbidities according to age. So in red and in orange, and partly also in yellow, those patients are deemed ineligible to full dose FCR. Maybe I can draw your attention to the 80 years of age panel. For frailty population, median overall survival is 4 years instead of 12 years. What does CLL mean for these patients? First, you have here the data published by the group of the Mayo Clinic in the United States. Tate Shanafelt published this, so these survival curves are meant for US people living in this region of the country. So CLL impacts the survival of patients, whatever the age. And now I move to France. We had a series of almost 200 patients aged 80, 81, 82, and those patients received first-line therapy, chlorambucil or chlorambucil plus rituximab or bendamustine plus rituximab. And as you see here, the median overall survival of those patients in a Western European country is 4 years. It means that CLL, for them, had the same significance than frailty. So when we start to give a chemotherapy to our CLL patients, it impacts overall survival irrespectively of age. So that's why when I answered the question, when I treat a CLL patient, my question is, which treatment improves overall survival? And at which cost in terms of safety profile? I show you here the data, some data on rituximab plus bendamustine or bendamustine alone. It's really important not to give chlorambucil alone in those patients because chlorambucil is a true first line and any subsequent line of therapy efficacy is jeopardized by the use of chlorambucil alone. So once you decide to treat your patient, you give the best regimen available in your center. So question 2, how to handle efficacy, how to choose between efficacy and toxicity. So as you know, FCR has many toxicities. FCR induces very profound immunosuppression, and the German group has reported the incidence of second cancer in their population of patients recruited in different clinical trials. And again, in multivariate analysis, being older than 65, receiving fludarabine-containing regimen and having many comorbidities, both influence the risk of developing second cancer. So when you think in terms of toxicity, also think in terms of long-term toxicity with those agents. And so the other question also is to use FCR at a lower dose. In terms of immunosuppression, there is no significant difference. It means that you will have a strong impact on the normal immune system. But maybe we can use a decreased dose of FCR. I know it's very popular in Russia, but it's also very popular in Brazil. 6 months ago, I gave a talk like this to Brazilian colleagues. In Brazil, they only use FCR. They don't even have bendamustine. And so they play with the dose of FCR depending on the age. This is extremely important to know. If you decrease by more than 20% the dose of FCR, you have to pay it, your patient has to pay it in terms of reduced PFS and reduced OS. And this is an important message. Instead of giving a low dose FCR, it's better to use other combinations of drugs in first-line therapy. And in the German experience, some risk factors were identified, and again, age, Binet stage C, and bulky disease. When you start giving FCR to a Binet stage C patient, you have a risk of toxicity, of course, because bone marrow reserves are not good from the beginning. But this is extremely important to keep in mind. Pay attention to the choice of FCR in your patients. This is our own experience in our region. We had exactly the same kind of results, and it is really a bad choice to reduce the dose of FCR unless you have strictly nothing else. But I think you have now at least 2 other drugs, such as obinutuzumab and bendamustine. The French CLL group has led a trial using 4 cycles of FCR plus 2 extra doses of rituximab to reduce the toxicity of cycle 5 and cycle 6 of FCR. And this is the result. The FCR result is excellent. Maintaining response with rituximab is good in the IgV unmutated population, but rituximab maintenance after FCR adds nothing in terms of overall survival and brings toxicity in terms of neutropenic events and infection. So rituximab maintenance after FCR is good to prolong PFS, but maybe too toxic, and in France we do not use it outside from this clinical trial. So, if FCR low dose is too toxic, why not bendamustine? Bendamustine was randomized against chlorambucil by the German colleagues, and you have here the results with a median PFS of 21.2 months and OS of 37. So, bendamustine is much better than chlorambucil as a single alkylating agent. But when you see the forest plot here, for patients aged more than 65 years, the difference is not so evident. So again, we have no clear data that bendamustine works really better than chlorambucil in this segment of patients. So why not reducing the doses of bendamustine? Well, you know now the results of a MABEL study. Our chlorambucil here in dark blue and our bendamustine in light blue. The difference in terms of progression-free survival is really significantly different. But pay attention to something. First, I'm going to show this after. The population in this trial is less comorbid than in CLL11 trial. The dose of our chlorambucil is really, really higher in this trial than in CLL11. And we still had some problems due to immune suppression. Bendamustine also induces very deep immunosuppression in terms of CD4 plus and CD8 plus T cells. So my advice would be to avoid bendamustine first line in patients just after a cancer, prostate cancer, skin cancer, thyroid cancer, any cancer, or those with repeated infections. Dose intensity of bendamustine is also important. You have to use it at 90 milligrams per square meter first line. If you reduce the dose by 20%, again, your patient pays it in terms of reduced PFS. So that's why when you compare things, pay attention to the dose you use and the number of cycles you use. So here, if you reduce bendamustine rituximab dose, PFS is 18 months and not 40 months like in the MABLE study. So when FCR is not eligible, what does obinutuzumab bring in our clinical practice? Yes? Oh, sorry. Yes. So first, obinutuzumab, again, very shortly, is a brand new monoclonal antibody. It's not a biosimilar of rituximab. Its mode of action is completely different, and it works in various subsets of CLL patients, including those with complex karyotype, TP53 mutation, Notch1 mutation, etc., etc. And so, since the antibody is much better than rituximab, we can use it with a less intensive chemotherapy dose. So the results of CLL11 are well known now. There is an advantage in terms of overall survival, in terms of progression-free survival, time to next treatment, and the rate of eradication of minimal residual disease. So definitely the combination of obinutuzumab plus chlorambucil in an unfit population is now the new standard. And you have here all the curves depending on the eradication of MRD. And since MRD is eradicated, being in CR or in PR has still an importance. When you can see here, the median PFS is very long, more than 3 years. And so this is what we have almost with bendamustine first line. So definitely this regimen can be compared in terms of outcomes with bendamustine, but it is less toxic. So again, as I said before, if you do not want to reduce the chances of your patients to benefit from a prolonged time to next treatment, maybe the use of obinutuzumab and chlorambucil is much more is a better choice, because in terms of toxicity, bendamustine 90 milligrams per square meter is really a problem with and especially in the very elderly population. Pay attention to this combination of drugs. So now I would like to compare comorbidities. You have on the right-hand side CLL11 trial, and on the left-hand side MABLE. So I owe to my colleague, Dr. Michalet, to present you this data today, because these data are not published yet. So the median comorbidities was 3 instead of 5. 56% had cardiovascular disease instead of almost 50 to 71. 40% had metabolic disorders instead of 53. And there was a lot of patients with reduced creatinine clearance in CLL11 by definition, and almost no patients in MABLE trial had such renal insufficiency. So again, we say that bendamustine can be safely used in patients with decreased renal function, but it's based out of nothing. MABLE is not the good answer to this question. So this is my definition in my everyday practice. When I try to balance chlorambucil, obinutuzumab, and RFC or R-benda, there are pros and cons. So here, I have to say I always use chlorambucil G101 for those patients aged more than 75 years of age, and irrespectively of comorbidities. So that's easy to remind. And above 65, I try to argue between GA chlorambucil and 4 cycles of FCR plus 2R, like the French clinical trials. But definitely, in younger patients, FCR outcompetes completely bendamustine. So use FCR instead of BR for very young patients. And then some subset of patients with 11q, I always use either GA chlorambucil or FCR, because rituximab chlorambucil and rituximab bendamustine are not so efficient against 11q. For those patients with very tumoral lymph nodes, I would rather use ibrutinib if it's feasible, because this agent is much more active, and the penetration of monoclonal antibody in huge lymph nodes is not very easy. So maybe for those patients, new targeted agents are better. But definitely pay attention to full dose Arbenda or full dose FCR in patients with anemia, neutropenia from the beginning. Those factors are linked with a high risk of reduction of dose because of toxicity. And for those patients with renal insufficiency, we have no clear data on arbendamustine. FCR is not recommended unless you decrease the dose by 50%, and that's not a good option, again. And so for those patients, I would rather use a combination of obinutuzumab and chlorambucil. This is very recently published papers in 2 Western world countries. The cost effectiveness of chlorambucil plus obinutuzumab has been considered really good. Good is not the adequate word. Acceptable by governments. It is a good value for money, as medical economists used to say. And to end, at the end of the day, with our group of hematologists and geriatricians, we proposed this chart published in Annals Oncology last year to remind that you have to use the best regimen in any line of any line of therapy, of course, but in the first line, really, you have to calculate life expectancy, etc. So the use of FCR or BR, I would not use dose-modified regimen. And for the vulnerable patients, the first choice, because there is an advantage in terms of overall survival, is obinutuzumab plus chlorambucil. And for those patients with relapse and elderly people, no more chemotherapy, targeted agents. Again, I spoke too much, I think, no? But this is the very last with some conclusion. As I said, anti-CD20 antibodies are the backbone of first-line treatment. And for fit or unfit patients, now in Europe, we consider using obinutuzumab with either FC or Benda or ibrutinib, venetoclax. And so really, rituximab will disappear from the first-line horizon for our patients. If full-dose FCR is not available, you can use arbendamustine, but it's a little bit more toxic, and we have similar results. So as Yevgeny stressed out before, I would rather advise to use this regimen of chlorambucil because it's more active in my practice, and it's also it gives very few toxicities. And in the future, we will have more and more data coming from both the UK, American, German, Italian, and French CLL groups on how to use either ibrutinib or venetoclax or even idelalisib in combination with obinutuzumab. So as you see, obinutuzumab has really become our anti-CD20 standard in the management of CLL. Thank you for your attention. I would be happy to take a few questions.
Спасибо большое.
Thank you very much, Loic. And I'm sure our colleagues do have many questions. Any questions? You're welcome. I'm afraid we have limited time for that. So could you tell me, very recently we heard that bendamustine is an option for the treatment of elderly patients. And now what? Are we changing our attitude, our consent? So it appears to be that bendamustine is now for patients younger than 65. And my second question is to Professor Nikitin mainly. What is your attitude? So do we measure minimal residual disease for the practical purposes? And my second question to you, what option do you consider when you select the treatment for patients? For you personally, what is more important? Overall survival, total remission, absence of toxicity, etc. Thank you. So three questions to each of the experts.
So first question, Arbenda is not better than FCR for younger patients below 65. That's it. CLL10 trial has not demonstrated that BR was equivalent to FCR. This is important to remind. FCR is more efficient. At the same level of MRD eradication, there is 2 years difference in terms of median PFS. So FCR is the best. BR can be used if FCR is not feasible. And then BR competes with obinutuzumab chlorambucil. Mostly, I would say, mostly in patients above 65 years of age. So above 65, you have FCR dose modified results. You have results, 24 to 36 months PFS. But you have exactly the same PFS with obinutuzumab chlorambucil. So for the same outcome, it's better to use the safest combination. And that's how I calculate things. FCR dose modified works, but less than you expect from full dose FCR. BR works, but it's as effective if you have to reduce the dose. And so every time you reduce the dose in your patients, it means that you didn't really adequately assess your patients. And so if you want to be quite, let's say, confident in prescribing your combinations, I would say that if you start from the safest, it's better than starting with with the most aggressive one. So again, in my practice, to be very honest, I never use arbendamustine. I use FCR full dose with GCSF support. 4 cycles instead of 6 if patients aged 65. And for all those patients non-eligible to FCR, I use obinutuzumab because it's reimbursed in my country. So I only use reimbursed drugs. BR in France is not reimbursed unless you prove patient was ineligible to FCR. But I mean, it's easy to give FCR or obinutuzumab chlorambucil. And second line, again, I used a lot BR after FCR, and we have published our experience. But median PFS is 15 months. So G-Benda in Russia is also roughly 15 months. 15 months PFS second line is very bad if you compare to ibrutinib, idelalisib, or venetoclax. So I know that you have problems having these new drugs in your clinical practice. So BR is absolutely not something, it's not forbidden. I mean, it's not, but in the upcoming years, I think you will have to change your way of thinking the treatment of CLL. And that's what we did with the introduction of such drugs. In 2015, arbendamustine was the treatment of choice in France. And it's not wiped out from the use of my colleagues, but really the introduction of ibrutinib and obinutuzumab has changed a lot of things in the way we think the treatment of our patients. And so I let maybe Yevgeny answer for the second part of the question, your attitude for...
Well, I'm afraid to stuck in this discussion, Loic, because we have just 1 minute before Frank should come to stage. But I want to ask you a question as well. So, Frank, please give us 3 minutes. So let's do it this way. Please tell me, do you use MRD in real clinical practice or not? Yes or not? Yes or no?
Главная цель.
And my final question. What is the most important target for you? Overall survival, progression-free survival, or toxicity when you treat the patients with CLL? Please say. It is the third question, actually.
Survival with the safest combination.
Я хочу спросить одну только...
I want to ask one thing. Well, I cannot avoid asking that. Let's go back to 2015, to France. Wonderful France. BR is a standard. So you want to administer BR, but patient 2 months ago had pneumonia. You are telling, well, if it's recent infection and it's a tumor, it's better to restrain from Benda. Yes, topic is complicated because what is instead of Benda? Yeah, the question is, how do you use CD4? I know that you published wonderful, wonderful work. So you measured CD4. So how you use it in practice, in your real clinical practice? Do you look at the level of T cells when you select proper treatment or not? Thank you.
The answer is yes, but it's, again, it's my practice. It's not a national it's not a national or international recommendation. In my practice, I always look at gamma globulins, CD4 T cells before I use a treatment. And I do this also for ibrutinib, to be honest. Because in my choice of BCR inhibitors, between idelalisib and ibrutinib, idelalisib is toxic to T cells, and ibrutinib, you can use ibrutinib more easily in patients with very profound T cell immunosuppression. And that's how I choose. I mean, it's not a recommendation, it's my practice.
Тогда, поскольку у нас
Then, as we will have some more option to talk to experts later, so now let me give the floor to Professor Frank Moschhauser, and he will make his presentation about the innovations in the clinical practice in the treatment of relapsed and refractory forms of follicular lymphomas. The floor is yours. You're welcome.
Okay, thank you very much. I first would like to thank you for the kind welcome and also thank the organizers for inviting me in this very nice city. I'm really in love with St. Petersburg, and especially the light of the spring in St. Petersburg. It's a fantastic thing. So I hope we can come back here and further improve our Russian. So my talk today will be on the options in relapsed and refractory follicular lymphoma. So you see that follicular lymphoma is not a single disease. It's a very heterogeneous disease, and you have many ways to evolve that. So when FL patients relapse, they can relapse in the main cases as a slowly progressive follicular lymphoma, with a small risk to transform 2 to 3%. And then there are two different pathways, the 6q1 or additional genetic alterations leading to disease progression. In a minority of patients, 5 to 10%, there will be a very aggressive clinical course of follicular lymphoma, but those patients will not transform. So there is a question whether there would be a defective immune response or a critical genetic event. And then you have less than 1/3 of the patients who are really the true follicular lymphoma, those with slowly progressive disease that doesn't transform. So when you look at this in Russian, it's not easy. You have many, many, many options to treat a follicular lymphoma. So it goes from watch and wait in the patient with late relapse and a low tumor burden to allogenic stem cell transplantation in those with multiple relapse and refractory disease. You have now many new drugs here, okay, but there are also different salvage regimen and autologous stem cell transplantation. What is important here to make the decision is to consider whether it's a first relapse, a second relapse, or a much later relapse, whether it has refractory disease, and then what would be the definition in the first line? Is it progression within 12 months? Is it progression within 24 months? And what were the previous treatments? What is the fitness of the patients, and what is the willingness of the patients to undergo different treatments? So everything has to be discussed with the patients. And probably in the first line setting, the best we currently have is the POD24, that is the progression of the disease within the 24 months of initiating treatment. And this has been published by Ms. Cazzulo. So this is probably the most reliable thing, and you see that we account here for only 90% of the patient. All the rest, no POD, would be relatively easy to manage with no strong recommendations. So, would it be possible to have that in English or not? No? Okay, so when you here, yeah, it's a bit far for me. Okay.
Франк, садитесь. Да.
Frank, take your seat, and you can easily speak up looking at the screen. Forget about the stage.
So the definition of refractory FL is multiple. We have seen that for POD24, it's really for the first line setting. But then you have refractory disease that can come later on. And then what is the definition? It's in progression of disease within 6 months of the last rituximab or of any type of regimen. Currently, it's more progression within the 6 months of last immunochemotherapy regimen, which is a little bit similar to the double refractories that has been used to register some other drugs. But it is important to underline that refractory disease should be progression of disease without documented transformation in the LBCL or even clinical suspicion. And this is something that is not clear in many papers where those transformed patients that have not been rebiopsied are put in the trials. So can we predict progression of disease or refractory FL? And the short answer is no. Sorry. We have more and more indexes, FLIPI1, FLIPI2, we can use PET, we can use SUV, but this is really work in progress. And so far, the different clinical biologic models have not been able to safely predict everything. So, in the end, the objectives Okay, so can we go back a few slides? I'm sorry for the inconvenience. Back, back, back. Not forward. Back one more. Okay, very good. So in the end, since there is no strong recommendation, what you would like for your patients is really to achieve the longest survival. And this is very difficult to measure, so probably the best indicator would be to have the longest disease control, progression-free survival. Does it absolutely mean that you need a second complete response? I'm not sure. Important is to preserve the quality of life and to try to have the less toxic regimen and the longest disease progression, even if you don't reach a complete response. And of course, all this regimen, many of the new ones, what you would like is to avoid very long-term toxicity. So this is forward. Avancer, c'est ça, hein? Non, alors je sais pas. Okay. As Loic showed, you have this ESMO recommendations that are not really completely helpful here. Again, all the different options are detailed here, immunochemotherapy regimen, maintenance. So you see that make a distinction between the first relapse and progression and the later relapse. So if you have got a nice response with a particular regimen, a long duration of response, and a good response to maintenance, you can give maintenance again, but there is no recommendations in later relapse. And if you go a little bit further, you see that, in fact, there are 4 types of questions. The first one is, what is the place of autologous stem cell transplantation as part of second-line therapy? And if you think, yes, there is a place, who are the best candidates? The second question is, what is the room for new anti-CD20? The third, what can we do beyond anti-CD20? And then what is the place of allogeneic stem cell transplantation? Let's look at autologous stem cell transplantation. The first paper that has been published in the pre-rituximab era, for whom most of the patients had not received rituximab as part of their first-line therapy, was the one by Pettengill and al. So those patients who all were relapsed and not refractory got a salvage regimen either containing rituximab or not, and then a rituximab maintenance. And you see that the best results in those relapsed patients who were rituximab naive was a 5-year PFS of 59%, which is not fantastic compared to the 43% without rituximab. Further analyzing what can be done, we have this very nice study from the German group. It's a retrospective study on the GLSG, and this time Zetloik POD24 or not POD24, whether you had received an autologous stem cell transplantation or not. And these are small numbers, but what you clearly see is that the red curves in plain, the curve of patients that had progression of disease within 24 months and had no autologous stem cell transplantation are doing the worst. And all the rest is equivalent. And this was true for progression-free survival and overall survival. But again, you have to remember that many of those patients, although they had received CHOP as part of their induction therapy, 71%, they had only for 20% of them rituximab as part of this combination, and 20% rituximab as part of first line, and only 48% rituximab in second line. So this is not the situation in France currently. Maybe this is close to the situation in Russia. I don't know. We can discuss that. We wanted to look at the same type of experience, this time in the PRIMA study, where all the patients had received rituximab as part of their first-line therapy. So this is the flow of the different patients. You see that in the PRIMA study on 1,018 patients, you had 463 relapsed, and in 58% there was no biopsy. So nobody knows what happens. In 42, there was a biopsy, and among this 42%, for 20%, there was an histologic transformation. And this histologic transformation, it was a main finding to see that it occurred very, very early after the disease course, that is, at around 10 months after starting treatment. So you are really in the POD24. So many of those patients were, in fact, deemed refractory or POD24 and had transformed disease. In the end, if you calculate the incidence, it should be around 9.4% at 6 years, but this is a simulation. Important is to see that most of this progressive transformed disease occurred within 1 year. And just let's have a look at the salvage regimen, which is given according to whether the disease is transformed or not. If the disease is not transformed, you can get any type of treatment regimen, and you see that the French preference was RD-HOG, so an intensive salvage regimen. There were also some R-CHOP, some RIs, but R-bendamustine is very, very small in our country. If you get histological transformation, then most of the physicians would go for an intensive salvage, which can be RD-HOGs, RIs, or RE-SHAP, or even RACVBP, so dose intense salvage. The other important finding was that in the transformed disease, you get more autologous stem cell transplantation, 42%, whether it was only 28% in the follicular lymphoma. And the good or the most important finding of this study was that if you had an autologous stem cell transplantation in patients with transformed disease, you had a huge benefit in terms of 5-year overall survival, 76% versus 22%. But there was no benefit at all if the patient had follicular lymphoma histology, no difference in overall survival. So we then looked at whether it was important to have progressive disease within 12 months or 24 months. And again, surprise, surprise, it was not the same as in the German retrospective study. We had no benefit. It's small number of patients, but no benefit in terms of progression-free survival or overall survival for these early progressors. So what is the place for autologous transformation, for autologous stem cell? To us, it's really probably the transformed disease, but the only way to really answer these questions would be to do this kind of trial. This was discussed at the LISA scientific board. All the patients would receive the GA101 DHOX salvage, and the responders would be randomized to either beam followed by GA101 maintenance, or the gadolinium regimen, which is challenging currently the autologous stem cell transplantation. And there is no consensus yet what are the patients we should include there, and we are currently running a questionnaire to see whether the group would be interested to do that. But currently, no autologous stem cell transplantation outside the context of transformed disease. So now, can we overcome rituximab resistance? The first point would be, what is rituximab resistance? And in fact, if you dig a little bit, nobody knows what it really means. It's a clinical finding. The patient progressed within 6 months of the last rituximab infusion, whether or not combined with chemotherapy. But if you look at the mechanism, is it loss of CD20? It's documented in a small number of cases of diffuse large B-cell, but not in follicular lymphoma. Is it CD20 shaving? It has been shown in CLL, but not in follicular lymphoma. The in vitro data suggest a loss of direct signaling, but we could not show that in the clinical setting. So probably one of the most consensual way is to see that there is a kind of loss of signaling and a loss of immune effector cells, which could induce this type of resistance to immune-mediated cell killing. And another issue that has been mainly brought up by the German group is the dose-related issue. If you can simply increase the dose, probably you can maybe overcome in some cases the resistance to rituximab, but this has not been properly shown in the clinical setting. So what can we expect from obinutuzumab in this particular setting? In fact, obinutuzumab is able to address some of these particular points. This has been shown by Evgeny. You know that there is an increased enhanced direct cell death. What has not been shown by Evgeny is that there is really a reduced CD20 internalization that probably may help. And there is also an enhanced DCC due to the particular molecular engineering of the drug. Let's try to illustrate that a little bit more in vitro. When you look at the time-lapse microscopy, when you use obinutuzumab compared to the other drug, you see that there is a death induction which occurs without any mechanical disruption. Also, you see that GA101 in culture condition really separate from rituximab into different cell membrane domain. And so this shows you the picture of homotypic aggregation. And this is probably one of the explanation of the different mechanism of action which leads to the increased cell death with reactive oxygen species and lysosomal permeabilization. It has been shown also that the DCC is increased by 100 times compared to rituximab and ofatumumab. And that GA101 also exhibits a superior whole blood depletion in all the different subtypes of Fc gamma R3 polymorphism. Something that has been done in Toulouse by Christine Beson, the co-worker of Loic in the basic science, is that the penetration in a three-dimensional cell culture system, which is called MALS, is completely different with rituximab and obinutuzumab. So this might be the same in different lymph nodes. You see, you have a limited penetration with rituximab at 24 hours, whether with obinutuzumab, it's going in the depths in the 3 dimension. This is probably due to the better penetration in the collagen 1 system in patients. So these illustrate you the many advantages this time in vitro for obinutuzumab compared to rituximab, which could explain what it overcomes rituximab resistance. The final point is the dose issue and the PK issue. The PK of rituximab was not great. There has been much effort to improve the PK findings with obinutuzumab. And the first finding was that there was a high variability of PK in individual patients associated with high tumor burdens. So if you used the 400 milligram, you had a huge variability in serum trough levels, whether if you increase the dose up to 600 or 800 later on, you had this variability going out. And also, if you use a higher dose of GA101, even a flat dose, which has been proved to be equivalent to this 2-dosing regimen, you have a much better disease control in patients with higher tumor burden. So probably increasing the dose also contribute to the efficacy of obinutuzumab compared to rituximab. And the first clinical evidence of this better efficiency was shown in this phase 2 study. You show that for the cohort of follicular lymphoma patient, there was an increase in overall survival, overall response rate to 55%. And the most important finding was that this increase was also true in rituximab refractory patients to up to 50%. The Gadolin study is very well known to you. This was the next step, of course, in relapse refractory patients to combine this most effective antibody to one of the conventional regimen used in the United States, bendamustine. The design is familiar. The definition of rituximab refractory disease also. You see that this trial recruited mainly patients around 63 years with high-level 3P scores at relapse and a reasonable percentage of high tumor burden, 1/3 of the patient and also 1/3 of the patient with bone marrow involvement. Most importantly, the median lines of prior therapy was 2 in the 2 arms, and all the patients were refractory to rituximab, mainly to a rituximab-containing regimen and not rituximab single agents. The overall response rate was not fantastic compared to bendamustine alone, but what was most important was the benefit you see on the right hand for the follicular lymphoma, benefit in terms of median survival with the primary objectives that had been reached, nearly doubling. The median OS was not enriched, and the time to next treatment was also nearly doubled and reaching 34 months compared to 18 months in bendamustine. The benefit was seen in nearly all the classes, but again, we underline the fact that it should not be given too late in the disease. If you have to give obinutuzumab in a refractory setting, it should be as part of second line and then maybe third line, but not later. Otherwise, like for every other drug, you lose the benefit of having these new agents in. So what was the price of this very effective combination? It was an increase in neutropenia, in febrile neutropenia, in infections, and in grade 5 fatal events. But this remained in this particular study manageable. But you have to consider that the gadolinium study was a very well-conducted study, but maybe not as thoroughly conducted as the gallium study that was recently published at ASH. And at ASH, they really paid attention very carefully to all the toxicity, infectious toxicity, second neoplasia, other severe adverse events. And the finding was that in the first-line setting, you had many, many more problems in the Banda arms and more problems in the G-Banda arms. So if you consider all that, my interpretation would be that it is not related to obinutuzumab, or it's only related to obinutuzumab when it's in relation to bendamustine, and especially if you give obinutuzumab maintenance after a bendamustine containing regimen. This is an issue, and we had now an alert from the French health systems showing that we really should pay attention to bendamustine because it increased the deaths and the toxicity even outside clinical trials. So I know that it's very popular in your country, but please carefully think of the role of bendamustine in this particular setting with maintenance if you want to use it, especially later on. So what can we do beyond this new anti-CD20? There are, of course, many, many, many new drugs, but I would like only to show you some of the examples, and that can be drawn considering the microenvironment in follicular lymphoma. We know that we have three players. We have the tumor niche with the pre-FL status and the FL tumoral cells. We have the stromal cells component, and we have the immune cells which play a role. And the three partners really interact to contribute to the oncogenesis. Let's look at what is the contribution of this T cell and AKIN compartments. So you have the bad guys, which is the T follicular helper cells and the Treg cells. And you have the good guys, which are the NK cells, the gamma delta, which increase ADCC, and also the CD8 exhausted, the CD8 cells, cytotoxic cells. So we know that the malignant B cells interfere with their T cell polarization and activity, and they promote Treg against T helper 17, for example. They induce CD40 with the T follicular helper cells, the secretion of IL-4, and they will really facilitate the rupture of the immunologic synapse. And then you can have many, many therapeutic targets coming from considering these different interactions. You could give, for example, lenalidomide, anti-CD137. You could give gamma delta T cell stimulations. You could give Treg inhibitors. And I want to show you some examples of that. Starting with lenalidomide, we know the pleiotropic effects of lenalidomide on NK cells, on CD8 cells, and probably on other components of the microenvironment. But the main finding was that lenalidomide is able to repair the immunologic synapse dysfunctions in follicular lymphoma with autologous tumor cells. And this was not only a biological finding, this was shown in a first relapse studies conducted by John Leonard. In this particular studies, lenalidomide was given in a continuous way, as long as there was a benefit, and there was only 4 infusions of rituximab. And you see that there was a benefit for these combinations with an early doubling of the median time to progression. This was better, but not really impressive. Can we improve that by giving more antibody, 8 doses, as has been done by the subgroup in the first-line setting with the same time, the same type of lenalidomide treatment, limited to 6 months? And this was shown by Eva Kimby at ASH this year. Of course, it's first line, but this time there is a clear progression, a free benefit survival. And you see that it seems to reach a little bit of plateau, and the median PFS has not been reached. And the same was true for the time to next treatment, with a very early benefit of nearly 20% that was really kept with a longer follow-up. So probably by increasing the number of doses of rituximab in combinations with lenalidomide, even in the relapsed setting, you could really see a benefit compared to rituximab alone, and even to lenalidomide alone. And this is the purpose of the Augment trial, which is nearly finished to accrual. Our idea was that since it looks so efficient with GA101, why shouldn't we do that in combination with lenalidomide? We have shown that the phase 1 dose was 20 milligram, as with rituximab, and we have now finished the analysis of the response rate combining GA101 and lenalidomide in follicular lymphoma. This will be shown at Lugano this year, and you will be surprised to see that the efficiency of this combination, even in some patients with late relapse and even in patients with POD24, is probably as good as the gadolinium regimen, but we need more follow-up to have the final confirmation of that. I told you that the Treg is important in terms of promoting follicular lymphoma, and you know that idelalisib was recently labeled in this indication. Nobody really knows how idelalisib works, and this is one slide that was given to me by Loic, which really considered the side effects of idelalisib in CLL and also in follicular lymphoma, and this work of the Bart Wanensbroek group showed that the PI3 kinase delta inhibitions, in fact, block the Treg differentiation favoring CTL expansion. And this may be the reason why it is toxic, but this also may be the reason why it is efficient in follicular lymphoma. And you see that the median PFS is around 1 year in double refractory patients who had received a median of 4 lines of therapy, which is not bad at all. Of course, it's not a very viable concept to use it as a single agent, and it's a bit toxic, but you have here a new demonstration that if you interact with the niche and the microenvironment and the different components, you can be effective and have an immune response. The follicular lymphoma T helper cells also are very important in terms of promoting the disease. It's an heterogeneous compartment. This has been clearly shown by the team of Carintat. And we know that those T follicular helper cells have a direct B-cell supportive activity and an indirect protumoral activity. And this could also have a link with genetic alterations. So when you see the different targets here, one is the PD-1 antibody. So should we try to disrupt this PD-1, PD-L1 component in the microenvironment? It's a little bit more complicated than that, because when you look carefully at this immunostat using immunohistochemistry, there only are a few infiltrating macrophages, but no tumor cells expressing PD-L1. On the other side, there is a strong expression of PD-1 on T follicular helper cells and T follicular regulatory cells, who both are functional, and also to a lesser extent on T cells that are mainly exhausted. So if you target this immunostat, you could have some pro-tumoral effect, but also some contra-tumoral effects. And nobody knows, so this should be explored in the clinic. When you use PD-1, the clinical experience is very limited. You see only 10 patients with follicular lymphoma using nivolumab, and another response rate which is comparable to many other drugs used as single agents, only 40%, and only for 2 of them you have a very durable response showing the immune responsiveness of the follicular lymphoma, but nothing really impressive. And we could also use a PD-L1 component. We have now many drugs out here. So this is why it was decided to use the preliminary Galen regimen, which proved to be very effective, and to try to further improve that by adding the PD-L1 component. And this is the goal of the Harmony study that is currently run. We are now in the expansion phase, and what I can tell you is that the preliminary impression in patients that were refractory to rituximab or rituximab-containing regimen is impressive. We also could use or try to fight against the subversion of the immune system by a different way. We know that ibrutinib as a single agent is not very effective in follicular lymphoma. Over response rate 20%, progression-free survival 6 months. But if you use it not to target the tumor cells, but the ITK of the T cells, and if you use it in combinations with PD-L1, as has been shown in the mouse model by Sajiv Barfi, it's very beneficial. You can induce a kind of vaccinal effect. So this is why in the LISA group we decided to have two strategies. The first one is to use venetoclax, obinutuzumab, and atezolizumab to try to induce a better eat-me signal and then to induce a kind of immune response. And then another one where we add ibrutinib to the combinations to have this vaccinal effect. So in one case, we have a maintenance of 1 year with atezolizumab venetoclax, and in the other case, we have a 1 year maintenance with atezolizumab and ibrutinib. And Loic and myself are the principal investigators of the Invectus, a very nice name given by Loic. The final thing I wanted to show you in terms of microenvironment is the role of the stromal cells. You have 3 compartments of stromal cells that might be important. And to make the story very short, what is useful to remain and to keep in mind is that either the tumor cells, the follicular B cells, or the follicular T helper cells may release TNF alpha in the surroundings and also interferon gamma, and thereby promoting an immune defect response, especially by the secretion of IDO. If you give IDO, you will depress your T cells, and maybe one of the way of fighting against that is to give together a PD-1 or a PD-L1 antibody and an IDO inhibitor. And this is currently starting in different diseases, solid tumors, diffuse large cell lymphoma, but we think that it would be very interesting to test in the follicular lymphoma setting given the importance of the microenvironment. Finally, the allogeneic stem cell transplantation and CAR T cells, who and when. I make it very short. The results of the allogeneic stem cell transplantation, you can cure the patient, but in fact you will only target a minority of patients, maybe less than 5 patients from 100 patients having follicular lymphoma. And the toxicity is huge. You see that the 3-year overall survival is not great, and then the more you go, the more you have toxicity. So to me, this should be given very late, at least after 1 or 2 immuno-containing regimen and new drugs. So maybe as 3rd or 4th line at least. And now you have a very challenging new drug, which are the CAR T cells. I showed you here the combination of the different domains from the Novartis compound, the antigen binding domain, the co-stimulatory domain, and the signaling domain. And in the preliminary data that has been shown with these CAR T cells, I think around 12 follicular lymphoma patients, they all reached a response. And in most cases, it was a complete response, and so far, a durable response. So the picture is a bit different in diffuse large cell lymphoma, where the median progression-free survival is only 6 months. But in follicular lymphoma, again, in line with the immune responsiveness of the disease, it seems to be a very long-lasting. And we will have very soon the ZUMA-5 trial testing in indolent lymphoma, mainly follicular lymphoma, these CAR T cells, and I really think this will challenge allogeneic stem cell transplantation in this disease. So, to summarize my talk, I think we now know that the room for autologous stem cell transplantation is small and probably limited to histological transformation. G-BANDA, of course, is labeled, it's registered, but G-based combination are probably as effective and clearly challenge autologous stem cell transplantation in refractory form follicular lymphoma. All the next steps should benefit from a better understanding of the biology to impact treatment choice. And we really should try more and more to target the microenvironment of the tumor and the disease component, the tumoral component. Should it be chemo-free? Should it be chemo with immune impact? Nobody knows. What we know is chemo-free seems to be very effective in subsets of patients, but it's not devoid of toxicity, and it's probably a different toxicity, and we need long-term to do that. And as I said, the place of cell therapy with allogeneic stem cell transplantation or CAR T cells should come probably in third line, fourth line, or later. And even if there are trials to do that in POD24, probably we will have nice response in later on, and this would be safer for the patient. So, to me, the immunomodulation strategy had the highest potential to change disease history. Thank you for attention.
Спасибо большое.
Thank you very much. Fascinating, fabulous, very informative presentation, colleagues. If you have any questions, you are waiting. You are welcome. Fascinating, fabulous in terms of informative level of this presentation. So while the audience is thinking, I would like to ask a very practical question. I understand that autologous transplantation is very rarely available, so very few patients who we can offer this option. But the data is showing that if this is histological transformation, then it's extremely effective. But if there is no transformation, then it's more doubtful story. So does it mean that we need to make biopsies to, let's say, any relapse of follicular lymphoma? We always biopsy as a must. Well, if you are planning to make autologous transplantation. So in Botkinskaya hospital, in my hospital, it's a different story. Can I ask you to raise your hands, those who always make biopsy if there is any relapse of follicular lymphoma? Please raise your hands. Every time biopsy. Well, we see. Well, I just want to understand whether it's widespread or not in the country. Well, Botkinskaya Hospital is a different story. Well, this is important practical moment. This is important from the practical point of view. You saw how many hands. Well, while the audience thinking, can I ask one biological question? Or I'd better not to do it. Do you perform biopsies in all the cases of relapses? My question, relapses of follicular lymphomas.
I think as much as possible we should do it, because you see that in many cases what you consider refractory disease might be a transformed disease. So we try to do it, but you saw that in the PRIMA trial, which was a large international trial, it was done in only 42% of the cases. So we try to do that more and more. We know that sometimes the disease is deep and it's difficult to biopsy, but with the CT scan, we can increase the percentage of patients that are rebiopsied up to 60%, I would say. And I would do that in all the cases when it's feasible, because it's so important. Then you will see the disease evolution, and you will see that there will be transformation later on if you miss the step. But it's no reason to give an autologous stem cell transplantation, according to my judgment, if there is no biopsy.
Ну, коллеги, поскольку...
Well, colleagues, as later on we will have brilliant chance to discuss everything in groups, and as we have no other questions right now, then I give the floor to our next speaker, and this is Professor Tumyan, who will speak about refractory forms of follicular lymphomas, interactive clinical case discussion. The floor is yours. You're welcome. Thank you very much, dear colleagues. I'd like to continue our talk about follicular lymphomas. We are aware that if you add on one non-toxic drug, which is rituximab, really changed, in principle, the situation with follicular lymphoma. But nevertheless, the disease did not become curable. We do know that today, the course of follicular lymphoma is guided by a number of parameters that we can characterize them as prognostic model. There are so-called pre-treatment and post-treatment model. As a pre-treatment model, currently we have just the clinical factors that can be characterized as sleepy, but again, it tells us about nothing. Why we need it is just to stratify the patients in groups, then somehow compare them in clinical trials, etc. But how the patient will respond to your question, sleepy doesn't give you the answer. There is another construction which is M7 Flippy. When to standard Flippy ECOG, you add on mutation of 7 genes. It seems that it may be partial solution of this question, that you manage to stratify the patients even better in groups, let's say, with more serious risks. But again, routinely, it yet cannot be used. We can try to look at the results of PET study after the treatment if the patient, let's say, has pathological accumulation. That this is not very good, but again, this is not so obvious as well, because there is new data coming that only level is not enough. We should look at the general metabolic activity and glycolysis. So again, it's not for routine. As Frank said, currently there is one model yet that can tell you that if you treat the patient with R-CHOP and he had a relapse within 2 years, it's bad. That's poor. But you will know about that just in 2 years, and you may not know that before. So it appears to be that approximately 20% of patients have early relapses of FL, and this is bad. But to find out, you cannot find it in advance. But as we are talking about the more or less indolent tumor, to overtreat 80% of patients versus those 20, no sense. And the disease, unlike aggressive lymphomas, where we are say it's one-shot disease and you have today as maximum as possible at first line. Well, follicular lymphoma, it's another tumor. It gives you several options of treatment, several chances, several opportunities that are not inferior versus each other. So most probably we will stick to more or less safe-based program. But when there is a relapse, you need to make a decision. And again, it's a very individual one. It depends on when relapse happened, how long was remission, what the patient was treated by before this relapse, what is the age of patient, comorbidities, previous treatment, FLIPI, GELF, what patient actually wants. You may not treat him or her because very frequently relapse does not require treatment as well as first line. Sometimes in relapse, the patient could be for a long time there before the moment comes when the treatment is necessary. So how to treat relapse? Well, you can go back to chemotherapy, and today we talked a lot about bendamustine. As always, when the new molecule comes, we are in, some anxiety. Wow, enthusiasm. We believe, oh, that's it. When Benda came, it seemed to us that it would resolve many problems of us. But in fact, yes, the molecule is really good, but not as simple as we used to think. Yes, this drug really has particular toxicity, and we see it more and more frequently because actually we started using it more wider and experience came. So that's a list of drugs that currently are under the studies in follicular lymphomas. So mainly here actually we speak about only non-chemotherapeutic options. So after Frank's lecture, now I'm absolutely convinced that future of follicular lymphoma is beyond chemotherapy field, beyond. Because even at first line you can do something to play a little bit with chemotherapy, but in relapse no place for chemo. No place for chemo. What here? New monoclonal antibodies, inhibitors of different signaling pathways, very interesting idelalisib, less interesting ibrutinib in follicular lymphoma at least. Venetoclax is interesting and definitely immune treatment. But the only reality today is that the only drug which is registered in Russia is obinutuzumab. Very good drug. and we got it, and we know it from gadolinium study, which was already mentioned. We know that, in fact, median progression-free survival 25 months in this group of patients, patients with so-called double refractory scenario, and which is the longest one, which is known for this group of patients, and there is the improvement of overall survival, which is also very important. This is a huge list of very different combinations where obinutuzumab can be used, adding to what Frank said. And I simply want to draw your attention to two clinical cases. Two cases how really, so actually who is that patient who should be treated with obinutuzumab. So I'm introducing you two cases. First, female, born 1950, follicular lymphoma, first, second cytology type in the inguinal lymph nodes on the right. So this is typical staging. We understand that this is cytological type 1-2, stage 2B, because this is pretty bulky disease in the iliac area. Intermediate risk by Filippi, and that's bulky disease. So that's always a question, how to treat, and we answer this question every time when we make the decision. I have to say that unfortunately, I am not aware about the data, how they treat patients generally in Russia. I can tell you how they treat in US. Somehow we know very little about our country versus other countries, somehow. So in US, for example, if you take this particular trial, they simply for 4 years analyzed routine clinical practice, not protocol, nothing, not a trial, so simply how patients are treated. 2,500 patients analyzed. 30% of patients are not treated at all. So they are in wait-and-watch category in our country. According to my feeling, according to my knowledge after interaction with you, it's about 5 to 7%, no more than that. Then, this frontline treatment, it's either rituximab mono or R-chemo. And when you start the first line, 20% of these patients do not complete it. Do not complete. Why? Well, most probably some of them progress, some do not reach complete or partial remission, stabilization, somebody lost for follow-up, somebody was given second line, etc. But you see, 1,600 started and completed only 1,000, about 1,000. That means 20% was lost somewhere, and 45% of patients they lost. 45% of patients who completed this treatment with effect, and then they go for maintenance. Not 100, not 90, but just 45% get maintenance. Rituximab is the first line. Now, if we go back to PRIMA study, which again we know very well, and the target was to answer, do we need maintenance in first line or not? Indirectly, we can get some information from PRIMA. For example, which chemotherapy was selected by the doctors, because actually it was simply investigator choice based. Mainly everybody selected R-CHOP, so that's the most popular first line for follicular lymphoma. Rarely CVP, and very rare fludarabine. But nevertheless, 200 patients were treated by RCVP. I have to say that RCVP, pretty prevalent regimen, which is also used in Russia. Now let's try to analyze how they treat with chemotherapy now, because PRIMA, we should understand, it was performed, let's say, pretty long ago. Now we have Benda, and 50% of doctors in the first line use Benda. 30% give CHOP, and 8% give CVP. So we have three options. When you have a patient with follicular, you can select out of three. I have to say that CVP is a pretty frequent option for Russia, because Benda is not quite very well available, let's say, not available as a first line. And if you have pretty elderly patient with a number of cardiovascular complications with first, second cytological type, so mainly we will use CVP. So in this female patient, our CVP was started. She reached just partial remission, and then we started maintenance rituximab. And unfortunately, with this maintenance rituximab, she demonstrates early relapse. Early relapse. And then the question is how to treat early refractory to rituximab and to alkylating agents. So that means double refractory. If we go back to gadolinium study, we can see here that in average, the median of previous lines like in GB, DAC and endoscopy, it was 2. But again, 80% of patients received only one line of treatment, previous line, only one. So that's the most optimal time when you can add on obinutuzumab and to give it to the patient and to get the effect. And this is what actually happened later on. So we give the course, the effect, and complete remission, and that's it. That's it. So the earlier, the better. So 6 courses GB and complete remission. So the earlier ibrutinib, the better effect. The earlier obinutuzumab, the better the effect. So one more clinical case when when it didn't work. So this is male patient, born 1949, who came with abdominal pain syndrome, lost about 8 kilos, and there was increasing of all groups of lymph nodes, peripheral and intra-abdominal. So this is bulky, 10 centimeters, bone marrow involvement. This is 4B stage, high risk group, high tumor burden, FLIPI3. Patient, just like in first case, we started our CVP, but what we got is just stabilization. Yes, situation improved, pain syndrome gone, no intoxication, but the tumor reduced by 25%. So what to do in this situation? Definitely, we have to admit that this line is not quite effective, so we have to switch to something different, either R plus chemo or maybe G plus chemo. We decided that this is a good time to switch to G chemo. Yes, please. Let's ask the audience to vote. Oh, can we ask the audience to vote? Let's do it. Please vote. But I already told them. Oh my God. You should tell me before. Oh, all right then. So let's put voting to the screen. So RCVP. So what we see here is a refractory case. So what do you prefer? To go back to rituximab or maybe to try to give abino, if you have any? Please vote. I think the answer is very obvious. Very obvious. So if possible, we need to switch to another monoclonal antibody. We tried. So at that time we had gadolinium protocol ongoing, so we were happy to include that patient into the protocol. But unfortunately, he was randomized in the group as of bendamustine monotherapy. So we gave 6 cycles of benda, and we got only a partial effect. But actually, patient status was okay. He felt okay and no intoxication, etc. But the tumor reduced only by 50%. Then 3 months later, the effect still ongoing, and then 3 months later, progression. Then what to do next? So we had our CVP, we had benda. What to do next? So probably voting is not so easy going. So then we administer R-CHOP. And after R-CHOP, we reached... Oh, well, let's simply go back to the presentation mode, because I'm afraid voting will not work. Yeah, I will do it this way. Yeah, I want to show you bendamona. This is option, which is also possible in a group of patients which were refractory to the previous regimen. Yes, the effect is very good, 76%, but median of progression-free survival is just 9 months. So the fact that the patient gave us relapse in 6 months, it was, well, actually very predictable. We could expect it. So we take him for R-CHOP, and after 6 R-CHOP, we reached again only partial remission. Let's try to vote now. What to do next? After the third line of treatment, partial remission, to keep him on maintenance, keeping this partial remission as an effect, or maybe to offer line 4. And then we need to understand if line 4, which one? We had CVP, we had benda, we had R-CHOP. So what could be possible line 4 if we make a decision that partial remission is not what we are satisfied by? Line 4, 66%. 66% chose line 4 and 36 maintenance. Well, I have to say, honestly, at that moment, I don't know what line 4 I could speak about, frankly speaking, yeah? Because patient is 65. So we make a decision to leave him on maintenance with rituximab. I have to say that maintenance rituximab So we have this meta-analysis data, which was published pretty long ago, where they included non-randomized trials, 2,500 patients with follicular lymphoma, to answer the question, do we need maintenance or not? So we saw the data of American authors. So they told us just 45% of patients go for maintenance as the first line. Why? Because in the first line, we did not get the influence, any positive influence to the overall survival, and that's the argument against maintenance, although we dramatically prolong the time of the next chemotherapy, and I believe this is a serious argument in favor of. In relapse scenario, maintenance not simply prolongs the remission, but also prolongs the survival. And this is meta-analysis data. Based upon this data, based upon our own experience, we make a decision to administer maintenance rituximab. And what is interesting, 1 year later, after 1 year of maintenance, the patient gave us complete remission. So the effect of the maintenance was accumulating. It was growing, rising up. So by 1 year, so we cannot identify anything into the mediasternal and abdominal area. So we get complete remission for 3 years, but unfortunately February this year, that means 2-3 months ago, the patient in the control examination demonstrates the relapse in the initial lesion, which are intra-abdominal lymph nodes. So what to do next now? I remind you, everything is in front of you. CVP, bendamustine mono, R-CHOP, maintenance rituximab, 3 years of remission, including maintenance, I'm counting last year, so 1 year maintenance and 2 years of remission without treatment, and now relapse. What can you suggest? R chemotherapy, G chemotherapy, clinical trial, if yes, which one and what? So let's think it over, what to do next. Microphone. Well, I'm confused. Yeah, I totally agree with you that in case of follicular lymphoma, radiotherapy can make miracles, and I have experience. And you know, sometimes one patient experience can impress you so much and you can remember it for so long. Yes, I have experience of radiotherapy of one female patient who did not respond to any chemotherapy at all, and only radiotherapy could stop the disease. The only thing I'm confused about is the localization. This is abdominal. For elderly, you know, for elderly patients, he's 65, well, maybe. But again, we came to the different conclusion. I don't know, the time will show whether we were right or wrong, because the patient just started this treatment. So we thought that his last bendamustine treatment was finished 5 years ago, and he did not get obinutuzumab. He was not lucky enough, let's say. So we decided to give him GB. I don't know whether we were right or wrong. I don't know, because the patient just started. He feels okay. Yes, this lesion in the retroperitoneal area, abdominal area, so a bit pain in the back area, in the area of back. That's why we made this controlling examination. So yes, masses in the retroperitoneum. So we referred him to GB. I don't know whether we're right or wrong. I will tell you next time. Thank you very much for your attention, and I'm finalizing. Would like to ask a question. Can I ask a question? Not to me, but I would like to ask a question. I would like to ask about the radiotherapy, because this is very important issue. In follicular lymphoma, you know, this is a very highly sensitive radio tumor. How frequently do you use radiotherapy, and when? Can I ask Professor Frank?
In fact, I don't use a lot radiotherapy, but in the multiple relapse setting, on the refractory setting with localized disease or relapse always in the same site, sometimes I have to say I give radiotherapy in combination with other immunomodulating drugs.
As a first line in a local form of the disease, do you use monoradio?
Спасибо.
Лучевую терапию вместе.
Radio plus mono antibodies, monoclonal antibodies, radio plus monoclonal antibodies, local. Let's say onset of the disease, that was, for example, local follicular lymphoma, and rituximab plus radio.
We are now waiting for the results of the German trial. which is really testing a short course of immunotherapy combined to radiotherapy. The discussion was always the dose of radiotherapy. Should we only have a very small dose, 2 or 3 times 2 gray, just to induce some kind of modification in the presentation of antigens and then give anti-CD20 antibody, or should we give the full dose in combination with that? So nobody has the answers, but there are some preliminary data showing that it's a good combination to do that in the localized setting. But at least, even in localized disease, I always think that there is some disseminated disease, so some systemic component, which should not be chemo, but immunotherapy, I think it's a good thing.
Спасибо большое.
Thank you very much. Yes, please. You're welcome. Microphone. Could you tell me, when the patient finalizes the treatment, the maintenance treatment, and you're ready to stop the treatment, how frequently you use PET in your study? And the same question with relapse, let's say, diffuse B large resolve transformation in the large B cell. Do you use PET, positron emission tomography?
So in the follicular lymphoma setting, we have the chance to have easy access to PET, so we use it on a regular basis, even outside clinical trials, at the end of induction. But so far, so more and more it comes into the practice, and it has been now recommended in the guidelines, because every FDG PET avid disease should be eligible for that. Now, to be honest, what do we do with the results we have at the end of induction? And if it's only a faint PET positivity, it doesn't change our decisions to go whether or not to maintenance. If it's a strong positivity, to us it's an indication of failure, and many physicians would try to rebiopsy and then consider a salvage regimen. Regarding the maintenance regimen, I don't think we can negativate a lot of strong PET positivity with maintenance. So it's really something to be given in patients that are in good response.
Any other questions? You have large experience using lenalidomide. According to my experience, although my experience only in patients with relapses and refractory forms, so patients with follicular lymphoma, they don't tolerate it pretty good, higher than 15-20 milligram because of neutropenia. You have to stop. So how can you comment? What dose? What is your lenalidomide dose? Do you start immediately or you titrate? Do you upgrade the dose? Do you titrate up the dose or you start from fixed level?
It's very dependent of the previous course of therapy. So maybe if you have given that very late in the disease after some cytopenia induced by bendamustine or other intensive regimen, it's more difficult to tolerate bendamustine to the highest dose. But in our experience in the Galen study, when we start with 20 milligrams, we had no problems to complete a 6-month cycles induction. And in the maintenance, it starts to become a problem, but we give maintenance at 10 milligrams. So you can easily complete 1 year at 10 milligrams. So 1 year total treatment and at least 6-month maintenance with 10 milligrams should be okay. And if you have problems with the creatinine level, you start with 15, and then you see what happens. If it's well tolerated, you keep that. If it's not well tolerated, you can go down to 10. But so far, honestly, I have not seen strong signal in terms of dose-dense response with lenalidomide, and many patients are only on 10 milligrams and do pretty well if they are true follicular lymphoma.
Well, dear colleagues, I think we had fascinating, fabulous session, and I'm sure we will continue our discussion in working group. And now we deserved coffee break, and as soon as we are a bit behind our timing, we had to finish at 11, and now it's 11:24. So let's start at 12. So let's give a chance to have good coffee. So please, we start at 12 in working groups. Thank you very much, and enjoy your coffee.